I'd like to talk to you today about medications and nephrotoxicity. Obviously, that's a big topic. I'll talk in general terms, and then we'll go through. I have pulled some cases of common and less common things. So I have no financial disclosures to reveal or at all. So avoid nephrotoxins. That's pretty much a renal consult, right? So very specific, very helpful. So that's pretty much every renal consult ever. It's not very helpful, I admit, and obviously not all nephrotoxins are created equal. Not all nephrotoxicity is created equal. So that we have to be aware that there's the considerations in what nephrotoxins might be acceptable, what nephrotoxicities might be predicted with given medications. So, and the other thing is we never say, oh, the kidney functions better, now you can resume all your nephrotoxins. So, the flip side is also not true. So we have to take into account what is nephrotoxic, how it's nephrotoxic, how it might interact with a patient's underlying disease or other medications. So medication-induced nephrotoxicity obviously is very important, very common. About a fifth of patients with acute kidney injury or AKI in the outpatient setting is due to medication. And it gets higher with elderly folks, and obviously we're taking care of a lot of elderly folks. And as the population ages, people get more comorbidities. As pharmaceutical companies develop more products, there's more agents that people are either available to them or they're on, so the rates of nephrotoxicity are expected to grow. The importance of early recognition in acute kidney injury, which I'll make a few points about as we go along, is that nephrotoxicity, if picked up early, can usually be reversible or predictable, and you can manage the nephrotoxicity or electrolyte imbalances that might be predicted with a given agent. So the mechanisms of kidney injury, obviously they're myriad and depends on the different agent. Some agents affect glomerular hemodynamics. These might be things like ACE inhibitors, which affect the efferent arteriole, lower pressure in the kidney, and can reduce glomerular filtration rate. Same with calcineurin inhibitors, CNI, which would be something like tacrolimus or non-steroidals. A lot of medications are toxic to tubular cells. They affect tubular function. They impair the kidney's ability to work, to clear toxins, to clear electrolytes, or to reabsorb electrolytes in some cases. Some drugs affect hemodynamics. Obviously, diuretics or medications that affect blood pressure will drop the blood pressure and can affect renal blood flow. SGLT2 inhibitors, which I know you heard about recently, are classic for that. So that's something that we keep in mind. Obviously, we're recommending 4 SGLT2 inhibitors, but keeping in mind that there can be some nephrotoxic effects that we need to be aware of. Some drugs are inflammatory or allergic. These can cause things like acute interstitial nephritis. Examples there, our friend non-steroidals, once again. Proton pump inhibitors are notorious for causing AIN. Interferons, anything that increases immune function can cause an interstitial nephritis. Gold salts and antibiotics, obviously, are the classic agent that causes an interstitial nephritis. Some drugs can cause crystals. These are things like acyclovir and indinavir. Acyclovir, especially when given intravenously, can crystallize in the tubules and impair kidney function. A lot of medications affect electrolytes. Potassium, high potassium with certain diuretics, certain medications, ACE inhibitors. Low potassium with diuretics, for example. Calcineurin inhibitors like tacrolimus sometimes can cause hyperkalemia. Hyponatremia is very common, and it's very often medication-related, especially in the outpatient setting. And there's other causes, rhabdomyolysis from statins sometimes, or clopidogrel microangiopathy. Those are less common, but things to be aware of. Underlying risk factors for any kind of kidney injury, especially with medications, are on the slide here. So people over 60, people with lower starting eGFR are obviously at more risk. People who are volume depleted may be at more risk. They're already maybe getting some kidney injury from volume depletion. So then adding another insult to that injury could raise the risk of nephrotoxicity. Multiple agents at the same time. Patients started on 2 or 3 medications that may affect GFR, could be multiplicative. Patients with diabetes and heart failure are at higher risk, and especially in the hospital, we see patients that are very sick with sepsis, very sick with decompensated heart failure, et cetera. They're at higher risk, and they're also receiving multiple medications, often intravenously, so they're at higher risk of nephrotoxicity. So the kind of an interim summary, because I wanted to get to some cases, are that renal injury is caused by medication that can usually be reversed if caught early. Drug-induced renal damage can be acute, can be chronic. You can see pre-renal, intrarenal, vascular, tubular, glomerular mechanisms. And I didn't go over post-renal, but things that are very anticholinergic can sometimes result in urinary retention and a post-renal type injury. Again, a variety of common mechanisms. There's quite a few mechanisms, but you can group them into categories. Electrolyte and acid-base abnormalities are quite common effects of a lot of medications. And then there's a list of different categories of drugs. It's basically every category of drugs has a potential for nephrotoxicity or has agents within that class that can cause nephrotoxicity. So I picked several cases. Some are more common things that we see. Some are, older drugs, newer drugs, et cetera. So just we can kind of go through the cases as examples of things that we see in practice fairly regularly. So case 1 is a 64-year-old woman presenting for routine follow-up. She has a history of osteoarthritis, reflux. She's got well-controlled hypertension and a couple surgeries remotely. Medications, she's on losartan, ibuprofen over the counter. She says she takes it occasionally, a couple times a week, and omeprazole for GERD. Her vitals are normal, her exams are unremarkable, and her labs are on the slide there. Normal blood count, her creatinine has a little more than doubled, up to 1.9 from recently, and her electrolytes are normal. Urinalysis is essentially unremarkable. There are a couple of white cells on there. Further evaluation was done. We couldn't really figure out what was going on, so the patient was referred for a renal biopsy, which looked like this, and I have the answer on the slide as well. So this is an acute tubular interstitial nephritis. I think this is the pointer. So what you're seeing here is a sample of renal cortex. There are no glomeruli on the slide. It's all in the interstitium. So the tubules are here. Now, normally these renal tubules are back-to-back, meaning that the renal tubules are touching each other, and there's not a lot of this material here in between, and this material in between is a fairly substantial inflammatory infiltrate. You can see a lot of mononuclear cells. There might be a few polynuclear cells, and then there's scattered throughout there are quite a few eosinophils, which is pretty much diagnostic of an acute interstitial nephritis. Other thing that you can see on the slide are there's some cells sloughed off into the tubule, so that's indicative of an acute tubular injury on top of the acute interstitial nephritis, and those things are often seen together. So she had an acute interstitial nephritis. Some authors will call it an acute tubular interstitial nephritis. I'll continue to use AIN just for simplicity. Accounts for about 20% of acute kidney injury, especially that seen in the outpatient setting, and especially if we don't have another cause. Obviously, if you see someone who's hypotensive and has been over-diuresed, et cetera, you have an explanation for that. But when you're really scratching your head, interstitial nephritis is a good thing to think about. It's a T-cell type 4 hypersensitivity or allergic reaction. Less than 10% have the traditional classic triad. So the original description was with a penicillin type antibiotic, and that was described as having rash, fever, and eosinophilia on the peripheral blood. A lot of people will be asymptomatic. A significant proportion might have one of those symptoms, but to have the classic triads fairly uncommon. And usually shows up with a rising creatinine weeks or months after starting a drug. Sometimes it can be 6 or 12 months after, but usually it's within the first couple of months. And the definitive diagnosis, unfortunately, requires biopsy. And then the hunt begins for what is the agent. So here's the list of medications that can cause interstitial nephritis. Antibiotics were the classic description, especially with the beta-lactams, but we can see it with a variety of other antibiotics, vancomycin, rifampin, sulfa is pretty common. NSAIDs cause a variety of different renal injuries, including interstitial nephritis, proton pump inhibitors, immune checkpoint inhibitors, thiazides, lithium, and a lot of the anti-epileptic drugs can result in interstitial nephritis, and allopurinol actually is another cause. So in this case, it was felt to be the PPI. She didn't really take a lot of non-steroidals. It could have been contributing, but the PPIs were more recent, and she took that every day. With stopping the PPI, the renal function did improve. There was a large cohort study published in Kidney International probably about 8 years ago, and they found that the risk for relative odds ratio for AIN with PPIs was over 5, so 5 times the chance of having an interstitial nephritis with PPIs or proton pump inhibitors. It's more common in older people, probably because older people use more PPIs. The chance of developing AIN isn't particularly high. The absolute risk is probably 3 to 5% for people, but because the drug is so prevalently used, it's the #1 cause of interstitial nephritis. Antibiotics, again, the classic beta-lactam, it's less common just because there's less penicillin and beta-lactams used than PPIs, but it is more severe and you tend to see more of symptoms with it. PPIs and non-steroidals in particular are both associated with interstitial nephritis. Obviously, NSAIDs can cause other types of nephrotoxicity, but with PPIs being available over the counter, patients can take them for years without being monitored, and they can get an acute kidney injury, which can then develop into more of a fibrotic type situation where the inflammation is going on, and patient's asymptomatic and then develops an irreversible chronic kidney disease. So there's a catch-22 with interstitial nephritis in that, one, it's a little bit difficult sometimes to diagnose. There's no good clinical, besides biopsy and index of suspicion, there's no good clinical way to diagnose it. Then trying to figure out which drug may or may not be responsible for it is also difficult. The symptoms tend to be nonspecific. Patient comes in with an elevated creatinine of unknown etiology. Maybe they have a rash, maybe they don't, et cetera. Other than the creatinine, serum tests are not going to be helpful. CBC is not going to be helpful. Urine EOs have been shown to be very nonspecific and very non-sensitive. So in other words, the positive or negative predictive value of the urine eosinophils are not very good, and it's recommended against ordering urine eosinophils, actually. Urine microscopy might show a sterile pyuria, may or may not show some white cells, as it did in this case. But again, that's pretty nonspecific, and lots of patients have a little bit of, a few white cells on UA. Traditional imaging, not useful. There's nothing shows up on an MRI, nothing shows up on a CAT scan, et cetera, ultrasound. There have been some authors that have looked at using Gallium scans. There have been some retrospective analysis. There was at least one retrospective analysis where they looked at 76 people who had an elevated creatinine. 23 of them had AIN, and they did find a suggestion that it was more likely to be a positive Gallium scan. Problem with the study is not everyone had a biopsy. Only 20 of the patients who were diagnosed with AIN actually had the gold standard biopsy. And probably more importantly, those investigators weren't blinded to the Gallium scan results, so they knew who had a positive scan. So they would be more likely to say that person had AIN if they had a positive scan. In patients that we think have AIN are on medications that may be difficult to stop. A patient with endocarditis with a very resistant bug and who may be at high risk for biopsy, a gallium scan might be useful in that case because you don't want to stop the drug necessarily and kind of see what happens if the underlying disease that drug is being used for is quite severe. AIN does improve with the discontinuing the agent. Depends on a high index of suspicion again. So we don't have a good biomarker. We have to have the index of suspicion. We have to look at the medications the patient was on and then consider a biopsy. So that delays the biopsy sometimes because you're like, well, the person's on a PPI, why don't we stop that and see if they get better? And then they don't get better, and then you go ahead and do the biopsy and see that they had something else. So, trying to decide if a person has interstitial nephritis or not and stopping a drug may delay the diagnosis. On the flip side, the longer you wait to start steroids, which is the treatment of choice for AIN that's not resolving with stopping a medication, the more fibrosis there is and the more likely that damage is going to become permanent. So again, drug-induced AIN, there's other types of interstitial nephritis that are not related to drugs, sarcoid being one example, but with drug-induced AIN, step one is going to be to stop the drug. Sometimes it's not that easy to determine the drug. The biopsy doesn't tell you what drug it was. The history tells you what drugs the patient's on, and you can think, well, what is more commonly associated with interstitial nephritis? But sometimes it's not that easy to necessarily identify the drug. And honestly, it's not always that easy to stop the drug. There may not be an alternative in some cases. Retrospective evidence does suggest that steroids are beneficial. They did try to do some retrospective analyses, which I have on the slide here. The problem was that since interstitial nephritis was described, steroids have been used, so it's kind of been the standard of care before the studies were done. There were 2 studies done early that showed really no benefit to steroids. Those 2 studies were retrospective, as all of them are. The problems with those studies are, one, that the patients who got steroids in the first study had worse kidney function to begin with, so might have been less likely to respond because of their underlying disease, so compounding there. And then in the second study, the treatment was started quite late, so the patients probably had a lot of fibrosis at that point. The larger, more recent studies that are standardized and had histology and biopsy-proven AIN, et cetera, had steroids started early, did show benefit. So we definitely use steroids in patients with interstitial nephritis, especially if the creatinine is quite high. The biopsy is useful, again, to not only for diagnosis, but to see how much fibrosis is there. If you have what looks like end-stage fibrosis in a kidney, you may not want to proceed with steroids because the likelihood of response is lower. Is there any questions as we go forward? Case number 2, this is a 60-year-old woman who has depression. She had surgical hypoparathyroidism many years ago, vitamin B12 deficiency, metastatic melanoma. She presented for evaluation of elevated creatinine. Began to rise after the initiation of nivolumab. Nivolumab is a checkpoint inhibitor. Her medications besides that medication included calcitriol and calcium for her hypoparathyroidism, B12 and citalopram. And her labs, creatinine was 2.2, baseline was 0.9. UA shows some sterile pyuria and proteinuria. There were no casts, no RBC casts, no white blood cell casts, and nothing else really on UA. The rest of her labs and evaluation was negative, including a urine culture. And this patient underwent biopsy as well. And this is her this isn't her biopsy, this is a representative of her biopsy. Looks a lot like the prior biopsy. So you can see here's the renal tubules, again, not up against each other. Like this is what they normally would look like, kind of back to back, but there's this inflammatory infiltrate here. Mostly mononuclear again. There are some eosinophils scattered through here. some tubular damage. You can see some debris in the renal tubules here and here. This material here is protein, so that would explain the proteinuria that we saw in her urinalysis. She didn't have much in the way of fibrosis, and the pathologist also commented that there was very mild arterial sclerosis, so not really much else on the biopsy other than this interstitial nephritis. So again, the interstitial nephritis looks like interstitial nephritis, whether it's a PPI or the checkpoint inhibitor, nivolumab. So checkpoint inhibitors, such as the medication in question, they inhibit ligands that, again, this is a nephrologist interpreting oncology drug, but they basically inhibit the ligands that cancer cells express. These ligands then suppress T cell function, T cell activation, so that when you block the T cell blocker, the T cells are able to infiltrate the tumor and then promotes host anti-cancer effects. So it increases immune function. The host immune function cells can identify and eliminate cancer cells. They've proven quite effective in a variety of different cancers, including melanoma. There's two categories that are two different antibodies that block these checkpoints in different ways. So this was published by Mark Parazella out of Yale in 2019, did a review of checkpoint inhibitors and acute kidney injury. There's several case series of AKI with checkpoint inhibitors. There's not a randomized trial or anything like that with regard to interstitial nephritis. But in the case series, acute kidney injury tended to occur early, within probably a month or two, a median of 14 weeks. But it can occur fairly late, over a year in some cases. The biopsy in acute kidney injury most often showed AIN, although there were some TMA, glomerulonephritis, minimal change, other pathologies seen on biopsy, not only AIN. Most patients have good outcomes. Most of them in this case series recovered renal function on stopping the drug. Some patients were treated with steroids. The importance of biopsy in these cases is that you want to make sure that the person does have a related acute kidney injury, especially in a drug that's effective against cancer. In this study, Mark Parazella described a patient who had an acute kidney injury from a different checkpoint inhibitor, and at biopsy had acute tubular necrosis, or ATN, and the drug was not discontinued, so the patient was able to continue on their anti-cancer treatment because the biopsy showed that it was most likely not the drug that was responsible for their acute kidney injury. Again, management. In some cases, you can just monitor if they have a mild acute kidney injury, especially if the drug is effective for their cancer. We usually recommend discontinuing the drug, and if it's severe and the creatinine doesn't improve on discontinuing the drug, then steroids can be used. This is the same review that from the prior slide, suggested that in some cases this drug is able to be restarted. Some people initiate the drug if someone had an acute interstitial nephritis and the drug was working against the cancer, and the drug's going to be restarted to start with low-dose steroids, but there isn't any data in that regard. Our patient did have an AIN. There was, as I showed on the slide, minimal fibrosis and minimal chronic change. She recovered quite well. I spoke to the oncologist, and for a variety of reasons, we elected to, most importantly, the cancer was in a remission, so we elected to stop the drug and monitor, and her creatinine came down to 1.2, so in that case, we didn't need to use steroids, and she continues to do quite well. Case 3. 67-year-old woman, type 2 diabetes. She has nephropathy, retinopathy, peripheral vascular disease, and she's coming back for wound care. She had been seen in wound care a week prior, started on antibiotics for a very severe deep soft tissue infection on the sole of her foot. Her medications are on the slide there, typical diabetes medications, empagliflozin insulin, metformin, lisinopril, gabapentin, and trimethoprim sulfa, which was started the week before. Her UA shows 2+ protein. She had proteinuria from her nephropathy, so that's not a new finding. It was otherwise negative. But the striking thing is her creatinine was 6. Her baseline was less than 2. Her potassium was also 6.1, and the rest of her chemistries and her CBC are normal. This is something we see quite regularly as well. So this is acute kidney injury and hyperkalemia from trimethoprim sulfa. Very common. Patients with mixed or deep soft tissue infections and diabetes with risk for hyperkalemia are already at risk for acute kidney injury, and trimethoprim and sulfa both have mechanisms that they can cause acute kidney injury that we'll go through. There was a VA study that was done several years ago. They looked at 500 veterans that were treated with treatment dose, or trimethoprim sulfa, and over 10% of those patients had an acute kidney injury of any sort, so that's a creatinine rise, or at minimum. The AKI, or acute kidney injury, did resolve on discontinuation of the medication. One patient in their 500 did require dialysis, however. There's really no other findings. In other words, pyuria is uncommon. There was no patient with eosinophils in the urine. Risk factors identified: diabetes, underlying chronic kidney disease, and hypertension. And as we'll go through, trimethoprim is notorious for causing hyperkalemia, similar to other potassium-sparing diuretics in the class. Risk factors for the hyperkalemia: concurrent use of ACE, ARB. We don't know about finerenone, but that's probably another risk factor. Spironolactone. There's one study that showed ACE, ARB with trimethoprim sulfa quadruples the risk of hyperkalemia. And that study was done with patients who were receiving not treatment dose, but the lower dose prophylactic dose of trimethoprim sulfa for PCP prophylaxis, or I guess it's PJP prophylaxis. So these are schematics of two molecules. This is trimethoprim on the left, amiloride, classic potassium-sparing diuretic on the right. You can see that they have very similar shapes. They both have this ammonia group up here, ammonia groups on the side, at least one, and they actually block the same receptors, we'll see. So how does trimethoprim, or how do these drugs cause hyperkalemia? So we're going to go back to a little bit of cell pathways, everybody's favorite part of nephrology. This is a distal tubular cell in the distal nephron. This is the lumen, or the urine side, blood side over here. So as fluid that was filtered by the glomerulus comes through the tubule here, sodium is reabsorbed and potassium excreted, driven by the sodium-potassium ATPase. So as the sodium-potassium ATPase does its job, sodium is pumped back into the blood or reabsorbed. The epithelial sodium channel, ENaC, allows sodium to come back in to keep driving the sodium reabsorption. And to maintain the electrical neutrality, potassium then goes through this ROMK channel here and into the urine and excreted. So if you block this channel, as you do with amiloride, trimethoprim, amiloride, and triamterene, so all the classic potassium-sparing diuretics, the result is hyperkalemia. So not only does amiloride block that, but trimethoprim does as well. So it's important to think of trimethoprim as a potassium-sparing diuretic, so you have the same cautions that you would with any potassium-sparing diuretic, whether it's trimethoprim, amiloride, or triamterene. So case 4, 73-year-old woman, type 2 diabetes, hypertension, depression, who presents to primary care. She has mild confusion. That was noted by the family, nothing too severe, but the family just said she just doesn't quite seem herself. And she's normally very active. She goes hiking, et cetera, but she's maybe a little bit unsteady on her feet. Nothing very subjective and not that easy to pinpoint, but she just doesn't seem quite right. Symptoms began about 2 weeks prior. Medications are on the slide there. Another patient on SGLT2 inhibitor, metformin, lisinopril, chlorthalidone, and sertraline. So her exam's unremarkable. She does seem a little confused, but again, it's hard to print. She's oriented, but just doesn't seem, maybe a little slow, or just different, off for her. Her routine labs are remarkable. Her sodium's 122, potassium's 3.4, chloride 70, BUN creatinine are normal. Glucose is normal, not normal, but 158. TSH is normal. And 6 weeks ago, her sodium was 131. On further questioning, it appears that the patient was started on sertraline a few months ago for some depression. So she had hyponatremia primarily from sertraline. Obviously, the thiazide diuretic played a role in, and her baseline sodium was a little bit low, but adding the sertraline on top precipitated the more severe hyponatremia, which was causing her symptoms. Hyponatremia is a sodium of less than 130 by definition. Severe hyponatremia less than 120. It's one of the more common electrolyte imbalances, and it's probably scary for us because it's harder to treat than, for example, hyperkalemia. And if you treat it too fast, it can cause problems. If you treat it too slow, it can cause problems. So it's not necessarily an easy electrolyte abnormality to contend with. Obviously, with hyponatremia, you want to rule out other causes. If she was really dehydrated or something like that, she could become hyponatremic from volume depletion, from heart failure. I put her glucose and her thyroid function on the slides to rule out things like pseudohyponatremia from hyperglycemia. But with hyponatremia, it's kind of like this presents often. Just subtle changes in maybe in gait, subtle changes in personality or cognitive function. Occasionally you can see some nausea. Sometimes you can see some headache. As it gets more severe, you're obviously more likely to see more severe symptoms, especially when the sodium's less than 120. More mild hyponatremia, and hers was not mild, hers was 122, but more mild hyponatremia, I'm talking 130, 128, can cause cognitive issues, can cause balance issues, and there's a higher incidence of falls even with sodiums in the low 130s, so it does raise the risk of fracture. So seeing a sodium of 130, 131 is something that should be at least addressed. So hyponatremia from medications, in this case it was the sertraline, and we'll get into that a little bit more. But thiazides, diuretics are classic for causing hyponatremia. SSRIs, other antidepressants and CNS active medications, some anti-seizure medicines, antipsychotics can cause hyponatremia. It's described with proton pump inhibitors, although not as common. Many of the agents, other than including diuretics actually, can stimulate release of ADH. So a lot of these drugs have an antidiuretic hormone-mediated type of hyponatremia. Thiazides are particularly notorious, partly because not only do they inhibit the ability to excrete free water, when a person gets volume depleted, the first thing that happens is ADH goes up, so they have a high ADH state, and then the thiazide, because it's working more distally, inhibits the ability to excrete that free water. When we see hyponatremia clinically in the outpatient setting, or even in the inpatient setting, it's often multifactorial. So you have patients on multiple medications that predispose toward hyponatremia, and maybe their heart failure decompensates, or they get volume depleted, or their nutrition gets worse. There's a tea and toast syndrome where people don't take in enough solute to be able to excrete free water, and then they get hyponatremic from that. So if you have patients that are on medications and have illnesses or situations that predispose to hyponatremia, that's where we see it more often. As far as SSRIs, very common and maybe not as recognized as perhaps it should be. It's well documented in case reports, case series, and actually in a lot of the manufacturers' reports to the FDA in approval, et cetera. All SSRIs have been associated with this increased risk of hyponatremia. Median time to developing hyponatremia is pretty early, probably within about 2 weeks, 9 to 13 days. It can occur quite late, and I think that the ones that occur late are when maybe a patient's on an SSRI, another medication gets started, they get started on a thiazide, or they develop heart failure or cirrhosis or something like that, so they're compensating for the SSRI, and then something else, they have another item or another thing that happens. I've seen people on an anti-seizure drug, an SSRI, and thiazide, and when the third medication was added is when they developed their hyponatremia. It generally resolves a couple of weeks after stopping the drug. Obviously, if a person has more symptoms, you may need to treat more aggressively to bring the sodium up, but with sodium, slower is usually better anyway. So in this case, we stopped the sertraline, and then her sodium went back up to the low 130s. Again, with SSRIs, the mechanism isn't 100% clear. We know it's ADH mediated, but as far as the details of that mechanism, it's not teased out completely. The pattern of hyponatremia with high urine osmosis and high urine sodium suggests an ADH effect. There are effects of serotonin renally that cause ADH release, and SSRIs may actually increase the kidney's responsiveness to ADH. So these things are all probably working together to result in hyponatremia. Interestingly, the SSRIs inhibit norepinephrine a little bit as well as serotonin, and that stimulates ADH release through a different mechanism, through the alpha-1 adrenergic receptors. So the class of antidepressants called the SNRIs that inhibit norepinephrine have also been associated with hyponatremia as well. So thiazides and hyponatremia, again, this patient had 2 different potential causes for hyponatremia. Thiazides are probably the #1 cause in the outpatient setting. Risk factors there include low muscle mass, low protein intake. Protein generates solute that the kidney uses to be able to excrete free water. Other medications that cause hyponatremia, as we talked about before, it's more common in elderly, more common in women, and other patients that have other comorbid conditions like diabetes, patients with cirrhosis, patients with heart failure. So thiazides cause volume depletion. They increase the effect of ADH from that, as I described before. And then you have the thiazide working distally to inhibit the ability to excrete free water to dilute the urine appropriately. And then contrast that with the loop diuretic that works more proximally within the kidney, so that it does inhibit sodium reabsorption proximally, but then when that fluid in the tubule gets more distal, that the free water is able to be excreted because the loop diuretic doesn't work at the distal tubule as the thiazide would. In patients who have decreased prostaglandins, whether it's from just normal aging or from NSAIDs, can inhibit urinary free water excretion as well. So a patient who's on non-steroidals, in addition to thiazide, in addition to SSRI, and maybe another medication that predisposes to hyponatremia is at high risk. So I'll open up to questions after here, but drugs can induce nephrotoxicity by a variety of mechanisms. Nephrotoxicity can be reversible in many cases if picked up early. It requires a high index of suspicion, certain medication, knowing which medications might be putting patients at risk for certain types of toxicities. Nephrotoxicity is increasing as our population ages and as more agents are being developed. And again, a high index of suspicion and knowledge of pharmacologic mechanisms is a key to early identification, intervention, in medication-related kidney disease. And I can open up to questions.
Hi. So with the PPIs causing AIN, how often should people on PPIs be monitored? And is it just simply the creatinine that you check, or just the BMP? Or?
Yeah, it's the creatinine that you follow. You could look at a urinalysis, but again, it's pretty nonspecific. I usually recommend after starting it a couple of months, and then probably twice a year after that. If it's going to occur, it's going to occur relatively early. In those cases, if it hasn't occurred in the first couple of months, then it's probably not going to occur. Of course, with PPIs, there's other issues with long-term association with chronic kidney disease. So I do check patients at least a couple of times a year and try to switch patients to H2 blockers if possible.
Okay.
Not necessarily for the AIN, but for the long-term risks.
Thank you.
So I've started a patient on an SSRI or SNRI. Should I be monitoring them in some way? And if so, how often? Or is it just clinical monitoring for hyponatremia?
I recommend checking twice a year, just a regular Chem7, a serum sodium level with that. Yeah, especially in people that may be at higher risk. I have caution when a patient's on a thiazide, for example, and then starting an SSRI. There's sometimes people on more than one. You might be on an antipsychotic and a SSRI. Those people I would check more often. Yeah. But at least, I say at least twice a year with the routine, with the creatinine and a routine Chem7.